Hello everyone, welcome to this module on respiratory system. The topic is obstructive sleep apnea. Obstructive sleep apnea. You can call it obstructive sleep apnea syndrome also, OSAS. Now I have seen that some students often skip this topic for your exam, thinking that this is not falling under the respiratory system or probably it is not that important. But let me tell you one thing, this is one of the favorite questions for examiners. So you can get this as a clinical scenario question as well. So you have got to learn this topic well. And let me tell you, this is very relevant clinically also. Probably at the end of the discussion, I hope that I will be able to convince you why this is such an important entity that you should know of. Okay, so let's begin with obstructive sleep apnea syndrome. So what are we going to do in this module? First of all, we will try to understand what this entity is, OSAS, and what are the conditions leading on to obstructive sleep apnea, and what are the clinical features of obstructive sleep apnea, how will you investigate and diagnose a case of OSAS, and how will you manage. So these are the subheadings in which I am going to discuss this topic with you. So let's start OSAS. Okay, first of all, what is this entity? Okay, it is very clear that this is some sleep disorder. Now when I say this is some sleep disorder, let's try to put it into a category. That is, you should know that there is a particular classification system by name ICSD-3, okay, which stands for International Classification of Sleep Disorders. Okay, so the latest one is the ICSD-3. So that is a body that actually classifies the various sleep disorders. Okay, I'm just talking of sleep disorders. I have not come to obstructive sleep apnea. In general, you have the classification system by the ICSD-3. And this ICSD-3 recognizes 7 different classes of sleep disorders. Okay, 7 different classes. So this is the third edition of the International Classification of Sleep Disorders. So they are classifying it into 7 major categories. So let's see what are these categories and where does OSAS fit into. Okay, the first category is insomnia. Okay, second is sleep related breathing disorders. Third is central disorders of hypersomnolence. Fourth is circadian rhythm of sleep-wake disorders. Fifth is parasomnias. Sixth is sleep-related movement disorders. And seventh is the miscellaneous or the other sleep disorders. Okay. In this module, our area of interest is this one, that is sleep-related breathing disorders. Because under these sleep-related breathing disorders, you have certain subcategories, out of which I would say 2 are most important. One is your obstructive sleep apnea syndrome or OSAS, and there is another entity that is CSA, which is your central sleep apnea. Central sleep apnea. Okay, all right. So this is the classification by ICSD-3. So if somebody is asking you what is OSAS, it is a sleep disorder. It is a sleep-related breathing disorder as per your ICSD-3. Okay, so that is what you have got to know initially. Now let's try to see more details into this topic. Okay, obstructive sleep apnea syndrome. So this is some sleep disorder where there is a ventilatory defect. Okay, there is some problem with the ventilation. Okay, it is actually a ventilation problem. Okay, this is actually a problem where, see the term obstructive sleep apnea. So there is some obstruction to the airway, okay, and that is the result of which you get this ventilation problem. And this disorder, okay, this disorder is characterized by a disruption of your sleep, okay, disruption of sleep, and ultimately what happens? There is excessive daytime sleepiness. Some individuals, you might not have this excessive daytime sleepiness. Instead of that, you will have excessive daytime fatigue. Okay, that is what happens. So this is what is your obstructive sleep apnea syndrome. Okay, so where the patient is having some obstruction to the airway, and because of that his sleep is very much interrupted, and because his sleep is interrupted, morning time, he is having excessive fatigue, he is very sleepy. So while he is driving, while he is at workplace, every time he feels like sleeping, okay, or he is too much fatigued. That is what happens in OSAs. Now let's try to see why this obstruction happens. Okay, why this obstruction to the airway happens, and where is this obstruction? That is what we are going to learn. Okay, so first of all, to learn something that is abnormal, you have got to have a clear idea on what is normal. Okay, so some very basic facts. What are you seeing here? You can see that I'm just trying to demonstrate the normal airway to you, which every one of you knows. So this is how the air would pass, correct? Okay, so this is how the air would pass. So normally you have the airway is very clear. You have adequate airway, especially the region of your pharyngeal airway. Okay, the pharyngeal airway, which I am trying to demonstrate, is without any obstruction, and it's allowing for the free passage of air. No problem, everything pakka, fine, no problem. Okay, that is what normally happens. So in obstructive sleep apnea, there should be some obstruction to the airway, correct? So your airway, especially the pharyngeal airway, in case of obstructive sleep apnea is compromised. How does it become compromised? In what way? That is what we are going to learn now. Okay. Another picture of normal airway anatomy. Okay, because subsequent pictures will be based on this picture, which is why I want you to know the approximate size, which I have diagrammatically represented here. This is the normal airway anatomy. So are you able to see the soft palate here? Okay, you can see the nasopharynx. You can see the mandible, the geniohyoid muscle, the hyoid bone, the epiglottis, esophagus. So first of all, understand that behind the soft palate, you have the retropalatal region. That is again a part of your airway. And behind the tongue also you have the retroglossal region. So overall, this the violet color representation is for the retropalatal region, and the pink color is for the retroglossal region. And you can see that is separately shown, just because they are trying to give you an idea of the approximate airway volume, because my subsequent pictures on airway compromise you can compare with this normal airway volume, so that you will understand how much the airway has got compromised. So remember, I told you in obstructive sleep apnea what happens is this particular airway, which I have demonstrated here, is some way compromised, resulting in an interruption of the free flow of your air. Okay, very clear. So that will actually interfere with the oxygenation. All right, so let's move on. Let's see the first abnormality here. First is, if you have a elongated soft palate. Okay, I'm considering a scenario where your soft palate is elongated. Okay, so the palate, instead of the normal position, okay, this green one which I am showing is the normal position. So instead of this normal position, you are having an elongation to this position. Okay, so it has gone slightly posterior. So when there is such an elongation happening, what will happen is that there is a compromise of your airway volume. Okay, you can say there is a change in the airway volume. You observe the retropalatal space and the retroglossal space. The retroglossal relatively okay, but still you see the compromise of the retropalatal region. You see this one should have been the normal outline. okay, which I am showing now, should have been the normal outline. But just because there is the palate goes behind, you can see there is a remodeling and it goes like this. So the airway volume is compromised. Okay, it is through a narrow region that this air actually flows. And what happens is that when you go to sleep, you know that in your sleep, especially in the REM sleep, that is the rapid eye movement stage, REM stage of sleep, there is a decreased input to the neuromuscular muscles, neuromuscular junction and the muscles, and because of which there is a decrease in the tone of muscles. Okay, there is a decrease in the tone of muscles, and because there is a decrease in the tone of muscles, what will happen is that the soft palate and all, the airway would be again compromised. Okay, the airway would again be compromised. That is why when you go to sleep, the further airway compromise actually happens. Okay, so the next issue is that because the airway is compromised when you are sleeping, there is the adequate ventilation is not happening, and then you tend to develop hypoxia, and then you develop the interruption of sleep occurs. Okay, so the sleep pattern becomes very much disrupted in such individuals. Okay, now is the enlargement of soft palate the only reason why a patient develops OSAS? Well, it is the most common reason why an individual can go on to develop OSAS. But other scenarios, like suppose if somebody has got an increased tongue fat, okay, an increased tongue fat, so what will happen is that the tongue actually goes more posteriorly. Even in normal individuals, when you go to sleep, slightly the tongue falls backwards. But when you have excess fat accumulation, what will happen is that it will go further backwards, and you can clearly see the compromise of the retroglossal space and to an extent your retropalatal space also. Okay, so you can see this is very much compromised. Yes, compared to the original, it is very much compromised. Okay, the airway is very narrow. So that is another reason why somebody develops a narrow airway. Any other reasons? Yes, you can have increased fat in the lateral pharyngeal walls. Okay, your lateral pharyngeal walls. This is the normal, this is the posterior view of the airway. So the first picture is showing normal, and you can see this is the lateral pharyngeal wall. And when there is fat accumulation, again what will happen is that the airway becomes very much constricted. Okay, that will again hamper with the normal airflow. Okay, and not just soft tissue enlargement, even skeletal abnormalities, because certain individuals will be having, say, either a micrognathia or maybe even a retrognathia, and because of these skeletal problems also, you will have compromise of your retropalatal and your retroglossal space, again leading to airway compromise. Various syndromes like your Treacher-Collins syndrome, okay, Treacher-Collins syndrome, as well as Down syndrome, these are again disorders in which there is a likely skeletal abnormality as well, and the chance of developing a obstructive sleep apnea also increases. So what have we seen so far? We have seen that the abnormalities, that is in your either the palate, the tongue fat, again the parapharyngeal region, the increased fat accumulation, skeletal problems, all these can produce a compromise of your airway, and that can lead on to obstructive sleep apnea syndrome. Very clear. All right. So we have understood what leads on to this, what are the abnormalities that leads on to this obstructive sleep apnea. Okay, so it is very clear that individuals who are obese, okay, because you often tend to equate obstructive sleep apnea to obesity, because it is obese individuals who are likely to develop this OSAS, and I am sure that by now you know why. Because in medicine, always remember, if you know the why, you are likely to retain the information longer. Because sometimes you might just casually learn a topic, and you might feel that after some days, you tend to forget it. Well, it can happen if you learn conceptually also, because we are all human beings, we tend to forget. But still, certain areas, once you understand the topic, it sticks longer. Okay, so always try to understand the why in medicine, so that learning is again more easier, and you find that it sticks longer also. Okay, all right. So you have understood why this occurs. Now, after having understood why this occurs, let's try to see what are the clinical features of obstructive sleep apnea. Clinical features. See, clinical features of obstructive sleep apnea is very simple. It's nothing complicated. You have nighttime symptoms, and you also have daytime symptoms. Okay, nighttime and daytime symptoms. So nighttime symptoms, you can just guess. Okay, that is a patient who is going to sleep. So there is again a compromise of the airway. Suppose an obese person is sleeping. So, the airway, it is actually, the air is finding it tough to go to these airways. So the first thing is that since the air actually goes through a narrowed airway, there can be vibration of the associated soft tissue resulting in snoring. Okay, so you can have snoring. Okay, because often this is noted by the bed partner. Okay, who would often say that he is snoring a lot these days. So there is snoring, you can have snorting, you can have, say, some sort of gasping type of respiration at times. Because what happens is that when there is an obstruction of airway for some time and there is some hypoxia building up in the patient, suddenly, he would have sometimes a gasp. So it is in that context that the patient develops a gasping. Okay, and also in addition to your snoring, snorting, gasping, you can have breathing pauses as well. Okay, so all these are the nighttime symptoms. Okay, so all in all, he is going to have a very poor sleep, a disrupted sleep pattern, and just because his sleep is not refreshing, that is the reason why he develops the daytime symptoms. So he may also develop daytime symptoms where he is feeling excessively sleepy, and also he is having fatigue. So that is what happens. Okay, nighttime symptoms and daytime symptoms. Alright, okay, so you have understood the nighttime symptoms and daytime symptoms. Let's just look through this table as well. Okay, the nocturnal symptoms during sleep. Okay, you can see there is loud snoring. Okay, you can have loud snoring, and you can get that gasping or a choking sensation in between cessation of breathing, sitting up or fighting for breath. That is when there is a severe hypoxia. Remember, every individual with an obstructive sleep apnea may not have all these features. It depends on the severity of symptoms, and there may also be some abnormalities. You might see the patient, the bed partner might notice him showing abnormal movements and thrashing in the beds. Severe sleep disruption, you might have a gastroesophageal reflux causing a heartburn. There may be nocturia and nocturnal enuresis. Some patients may develop insomnia and excessive nocturnal sweating. Okay, why I say is because the patient often feels this, it is rather than, the most of the patients would not develop insomnia. What they would say is that the sleep would be very much disturbed, and when they wake up in the morning, they feel it is very much a disturbed sleep. So, but some patients, as I said, they would have a insomnia, they are not feeling sleepy, may be seen in some patients. Okay, now these are the nocturnal symptoms. And daytime symptoms, excessive daytime somnolence. But along with this somnolence and fatigue, see, once these symptoms are prolonged for long, you can have behavioral changes as well. Patient might feel increasingly forgetful because he has not had a good refreshing sleep. That A good refreshing sleep is very important for a good memory also. So you'll have forgetfulness, personality changes. Now this is also very important, okay, because some men, can even complain of decreased libido and or impotence, erectile dysfunction. There may be dryness of the mouth on awakening, morning headache, retrograde amnesia. Children may be having hyperactivity and sometimes hearing impairment. So these are the list of daytime symptoms also. Okay, so you can have daytime symptoms as well as nighttime symptoms, and these symptoms, if you are having certain comorbidities or certain risk factors, you are more likely to develop the obstructive sleep apnea symptoms. That is, let's see what are the risk factors for developing OSAS. Remember, OSAS, it's always males more than females. Males have a higher chance of developing OSAS compared to females. Increasing age is again a risk factor. Menopause, that is, in females, more chance of developing OSAS is after menopause, and also those individuals who are obese. If the body mass index is above 25 and more so if it is above 30, the likelihood chance of developing OSAS is very high. And also you might have noticed some individuals having increased neck circumference as well as your waist circumference. So those individuals is again a clue that they might be having a compromised airway. So increased neck circumference. Certain races, can be predisposed to develop OSAS. Okay. And alcohol intake also, those who are chronic alcoholics, those who are smokers have increased predisposition to develop OSAS. If you use some drug, like drug abuse is also related to OSAS. Familial aggregation is there. That is, if you have someone in your family with OSAS, there is a likelihood chance that you also may develop OSAS. And if there is some concomitant nasal allergies, okay, then the likelihood of developing OSAS increases. Even if you are not morbidly obese, if you have concomitant nasal allergies, you are likely to develop OSAS. Endocrine diseases like your acromegaly, okay, endocrine diseases like your acromegaly, hypothyroidism, even Cushing's disease. So all these are likely to develop OSAS. And dysautonomia and disorders with craniofacial abnormalities like your Treacher-Collins syndrome. So these are the individuals who are at higher risk of developing these symptoms. So after having seen the daytime symptoms and the nighttime symptoms, let's move on to see what are the examination findings in a patient with obstructive sleep apnea. So physical examination findings, as is expected, the most striking would be the obesity. Most of the individuals would be obese. It is not that 100% of individuals will be obese. You can have an individual maybe with a Treacher-Collins syndrome who is not obese, but still he is having a obstructive sleep apnea. So that is, if you are having some craniofacial skeletal abnormalities, you can still develop OSAS without obesity. So the body mass index would be high, okay, and increased neck circumference would be there, increased abdominal circumference would be there, and you find that in some patients there will be a edematous uvula, a low hanging soft palate. Sometimes, especially in children, you will have large tonsils and adenoids, because in such individuals even children also may develop OSAS. Retrognathia, micrognathia, and very important. Now this is very important. Patients may have hypertension, cardiac arrhythmias, and evidence of congestive cardiac failure. Now, why? See, this is an airway problem. Why should there be a hypertension? Why should there be arrhythmias? Why should there be a heart failure problems? That is what we are going to learn. See, OSAS is not just any respiratory airway disorder alone. This has its own systemic implications. Because at the end of the day, what happens is that when there is an airway compromise, there happens to be a hypoxia developing. And when you have hypoxia, you can have consequences on multiple body organs and body systems. Okay, now I'll just show you a flow chart of various pathophysiological events which leads on to these other manifestations. Okay, like hypertension, arrhythmias. See, when there is intermittent hypoxia, Okay, let's first of all see what are the key pathophysiological events leading on to these other manifestations. When there is intermittent hypoxia, when there is a sleep fragmentation, when there are swings in the airway intrathoracic pressure as well, subsequently that results in certain consequences like oxidative stress. You will have activation of your sympathetic nervous system, especially when there is a hypoxia. So there is a HPA axis activation and increased cardiac preload and afterload. So lot of changes are happening. So the sequelae to hypoxia is a series of mechanisms that would affect multiple body systems. Clear? And what is the consequence of this? You can have increased blood pressure. I told you hypertension may be there. There will be metabolic dysregulation. See, not just that obesity predisposes to OSAs, even when an individual is having a sleep apnea, that can itself, he might be sleeping, excessive daytime sleepiness would be there. So his activity would be very much restricted. So he will go obese. There will be metabolic syndrome developing. So it is almost a vicious cycle between obesity and OSAs. OSAs, can result from obesity. At the same time, OSAs can lead on to obesity as well. There is systemic inflammation by release of certain cytokines because your sleep is very much disturbed. Endothelial dysfunction and myocardial, important myocardial dysfunction also. Okay, and that results in what all? Hypertension, diabetes mellitus, coronary artery disease, cerebrovascular disease, arrhythmia and heart failure. Now this is very, very important. Now especially hypertension. Many of the obese individuals who come to you with a hypertension, probably they are having obstructive sleep apnea also, which might be the actual contributory factor for development of hypertension in the individuals. So you have got to keep that in mind. Very, very important. Okay. So just keep this in mind because in the exam, sometimes, they might put these as distractors. They might say the patient is having a disturbed sleep and they might say that he is a diabetic, hypertensive. Remember, all these can fit into a obstructive sleep apnea syndrome. Okay. And the patients, the cardiac mortality is again one common mortality among patients who are having obstructive sleep apnea syndrome. Even arrhythmias, sudden death, all can happen. Okay. Alright, so we have seen in detail regarding the obstructive sleep apnea and why it occurs, correct? So we understood, okay, what is happening to the airways and what are the symptoms, the nighttime symptoms, the daytime symptoms. Okay, we have seen that in detail. And after that, let's now see how can you grade the severity of obstructive sleep apnea syndrome. Okay, you can even call it obstructive sleep apnea hypopnea syndrome. Okay, for which you have got to understand what is this apnea and what is this hypopnea. So let's understand these two terms. So once we understand these two terms, we will try to divide this OSAs into mild, moderate and severe categories. Mild, moderate and severe. So first of all, apnea. So what is this apnea? See, apnea means, you are having a cessation of airflow. Okay, a cessation of airflow or breathing for more than 10 seconds. That is what you call apnea. Whereas hypopnea is a slightly less severe condition where you are having a airflow limitation. Okay, there is a airflow limitation that is more than or equal to 30%, and there will be a decrease in the oxygen saturation. That is, you can measure on your pulse oximeter. There is a decrease in oxygen saturation by 3%. Okay, so that is what happens in a hypopnea. Okay, you understood what is apnea, what is hypopnea. Okay, and this decrease in oxygen saturation, whether it be apnea or hypopnea, when it develops in an individual, sometimes it can arouse the patient from the sleep. Either he can wake up and gasp for breath, or sometimes his sleep might be very much disturbed and he might be turning around, just trying to wake up, and you can, if you are the bystander or maybe the sleep partner of the patient, you can actually see that he is having a very much disturbed sleep. He's turning around here, there. It's because in between he is not getting the breath. Okay. All right. Now you can divide the obstructive sleep apnea into mild, moderate and severe based on something that is known as AHI, which is your apnea hypopnea index. Apnea hypopnea index. So what is this apnea hypopnea index? It is the number of apneas or hypopnea episodes per hour of sleep. Okay, that is the number of episodes of apnea or hypopnea per hour of sleep. So how do you calculate? First of all, you calculate the total number of apneic or hypopneic episodes, and then you divide it by the total number of hours of sleep and you find out the apnea hypopnea index. A mild obstructive sleep apnea means the apnea hypopnea index is between 5 and 14. Okay, between 5 and 14. A moderate one is where it is between say 15 and 29. So a severe one will be where it is more than or equal to 30. So that is how you grade obstructive sleep apnea. Okay, obstructive sleep apnea based on the apnea hypopnea index. So if somebody is having say 45 episodes, okay, he has slept for say 9 hours. Okay, so then that means it is the index is 5. Okay, the index is 5. So similarly, you have to calculate the total number of apneic or hypopnea episodes per hour of sleep. You divide and find out the AHI, and thus you can identify the severity of obstructive sleep apnea. So that is clear. Now you have got to know the names of two scoring systems, that is to assess your sleep quality. That is, so just know the name. One is a Epworth sleepiness scale, because previously they have asked one factual question, this is related to what? The Epworth scale is related to what? So this is a Epworth sleepiness scale where, you're trying to find out, what are the scenarios in which the patient would doze off or sleep. Like you see the 8 situations are given, like sitting and reading, watching television, sitting in a public space, and he is asked to score. 0 means, in that particular situation, he will never sleep. For example, if you take the first one, sitting and reading. The questionnaire means when you are sitting and reading something, do you doze off? Do you sleep? 0 means you would never doze. 1 means slight chance, 2 is moderate, and 3 is higher chance. So that is one. That is your Epworth sleepiness scale. And next is your Stanford sleepiness scale. Nobody is going to ask you the individual components, but know these two names, Epworth sleepiness scale and Stanford sleepiness scale. Okay. All right. So this also is a scale rating from 1 to 7. Okay. All right. Now, having understood the symptoms of OSAS, let's come to the diagnosis of OSAS. Now, the diagnosis of obstructive sleep apnea syndrome, the gold standard for the diagnosis, is a polysomnography. That is the gold standard. Okay. So polysomnography means it is usually done at the hospital. You can do it at home, but usually it is done in the hospital settings, where the patient is asked to come to the hospital, and you are obtaining an overnight sleep recording of the patient. You are keeping the various electrodes, like you will have the electrodes like EEG electrodes, you will have the EOG electrodes, you will have a nasal flow monitor, okay, so as to measure the airflow. You will have the belt around the thorax and abdomen, that is to see your how much your airway effort is there by your rib cage and abdomen. Okay, belts, thoracic and abdominal. You will have EMG, okay. You will have your SpO2 monitoring. You will have your EEG monitoring. So all this is included in this single polysomnographic measurement. And polysomnography, let me tell you, this is one of the most important tools for evaluation of sleep disorders. You remember when we started off, we said there are lots of sleep disorders. So why all these are included in your polysomnography is because they have their own importance. I'll tell you the importance in case of obstructive sleep apnea here. You need not know in too much detail about polysomnography, but you should understand that this is an entity where you are trying to measure or assess the sleep. Rather than measure, you are assessing the quality and quantity of your sleep, and you can diagnose various disorders as well. So gold standard is going to be your polysomnography. I'll just show you the picture of a polysomnography. This is one patient, in a hospital. We have it in our hospital. We have a separate room should be there for doing a calm, quiet room where the patient can sleep peacefully. Okay, and you're seeing all these machines the electrodes being attached. You will have the chin electrode, that is the EMG. You are seeing the nasal airflow also is there. Are you seeing the belts around the thorax and your abdomen? Okay, so you will have a saturation probe also to measure the oxygen saturation. The ECG leads are there. Okay, so everything is there in this polysomnography. So that is going to be your gold standard. So let's see what are the polysomnographic abnormalities that you can expect in a obstructive sleep apnea patient. But before that, let me tell you one basic point about the inspiratory pattern in case of obstructive sleep apnea. See, this is your normal inspiration and this is your normal expiration. In case of OSAs, what happens is that you can see in normal individuals, the peak of inspiration is at around the middle, correct? Is at around the middle. But in case of OSAs, there occurs a flow limitation and you will have an early inspiratory peak as you can clearly see here, okay? And then it is having a plateauing and slightly it is having a scooped appearance, and then it is the expiratory phase. Okay, so there is a plateauing and a scooped appearance as well in between, and then there is a expiratory phase. So that is one abnormality that you have with your because of the airflow limitation in your obstructive sleep apnea. Okay. Alright, so are you with me? Let's see what is the polysomnographic abnormality in case of your obstructive sleep apnea. So whenever you have obstructive sleep apnea, you have got to have a correlation between your airflow and the effort. Effort means the effort of your rib cage as well as your abdomen, because normally when you respire, there are movements of your rib cage and abdomen. So normal individuals, when there is a airflow is there which is normal, you have good respiratory effort as well. Suppose there is a obstructive apnea. What will happen is that in this particular period, you can see there is an apneic episode. Cessation of breathing. When do you call it apnea? Cessation of breathing for more than 10 seconds. So there is some apnea here, and even at that time the effort is there. Effort is there. When you have an apnea period, whereas the effort is also not there, you will call it central sleep apnea. Okay, so that is one difference between your central sleep apnea and obstructive sleep apnea. Obstructive sleep apnea means the problem is with the airway, so which means there is some obstruction, so which means the flow will be reduced, there will be an apneic episode, but still you will have your ribcage and abdomen working, because there is no central nervous system problem that is affecting the movement of your ribcage and abdomen, so that will happen. But in contrast to central sleep apnea where both will be affected. Okay, so let's just see the polysomnography. You're seeing a part of the polysomnographic recording of an individual. You see there is EEG, oxygen saturation, airflow, thoracic and abdominal movement. I told you we have separate bells. Now you see, are you able, you tell me now, yes or no, are you able to see periods of apnea in the airflow? Yes, periods of apnea, these are the periods of obstructive apnea. Yes or no? And even during the periods of apnea, are you able to demonstrate that the breathing pattern is there? The rib cage as well as your thorax is moving, yes or no? Yes. And are you able to demonstrate, let me just wipe everything off, are you able to demonstrate, to observe that there is a decrease in the oxygen saturation during the apneic episodes? Yes. You can see there are dips happening, and every dip is happening in the period of apnea. Okay, every dip is happening in the period of apnea. So this is what happens in obstructive sleep apnea. Even if they ask you a clinical scenario with a polysomnography, first of all, maybe the clinical scenario itself you will be able to diagnose it as OSAs. But still, if you want to confirm, you see first of all whether you have apneic episodes. So you saw there is apneic episode. Next you look, what about the thoracic and abdominal movement preserved? Also, what about the oxygen saturation? Is it dipping in the apneic episode? Yes, this is obstructive sleep apnea. As simple as that, as simple as that. Okay, so that is how you will diagnose. Okay, so we have learned that the cornerstone in the diagnosis is your polysomnography. But remember, at the same time, you evaluate for the other contributory causes. What is the lipid profile of the patient? Is he having some endocrine condition like acromegaly, hypothyroidism? Because see, hypothyroidism is a treatable condition. So you will have maybe a hypothyroid individual with a macroglossia. So you treat the hypothyroidism, patient is going to improve. So evaluation is also important. If there is any other contributory factor, okay, very important. So after having seen this in detail, let's go to the treatment of obstructive sleep apnea syndrome. So first of all, you have got to have in the treatment, you have got to advise the patient a behavioral and lifestyle modification. Behavioral and lifestyle modification, by which I mean, see, he might be an obese individual, so you must ask him for weight reduction. He can do exercise, okay, he can go for a morning walk, he can reduce his food intake, reduce intake of oily foods, somehow attain weight reduction. And also no alcohol, especially near bedtime. That is what they say. Okay, especially near bedtime, if you consume alcohol, your airway defenses are again very much compromised. More chance of your airway getting compromised, your tongue falling backwards, because you are the alcoholism per se can contribute to the compromise, because the central nervous system drive will be very less, which will contribute to further narrowing of the airway passages. So no alcohol, no smoking, okay, no drugs, okay. Drug means no drug addictions, okay. So this is very, very important. Okay, drugs, I do not mean the pharmacotherapy, okay, no drug addiction. So all these can contribute. So that is very, very important. Okay, this is one important aspect of management. Remember, I started off with this. Behavioral and lifestyle modification. That is what you have got to write. Okay. So after behavioral and lifestyle modification, second point, okay, after behavioral and lifestyle modification is that you can go for CPAP. That is continuous positive airway pressure. So this is one method which is often used by individuals who are having moderate to severe obstructive sleep apnea. So you see the CPAP, a continuous positive airway pressure is given, so that this will splint the airways open. Okay, the pharyngeal airways which are closed, that will be splinted open, so that you will not have the apnea and hypopnea. So CPAP is, remember, out of the treatments for obstructive sleep apnea, this has the best evidence. Okay, previously they have asked one question also of a patient who had a moderate obstructive sleep apnea, and they asked what is the treatment. This is going to be a CPAP. Okay, very, very important, that is CPAP. And third is you can go for oral airway devices, that are artificial devices which will help you. Okay, and I'll just show you a picture of one. You see here, it's a custom made appliance, which is worn while you are sleeping. So which will actually shift your jaw forward and prevent it from falling backwards. So there are various devices, some of which can prevent your jaw from falling backwards, some which prevent your tongue. So there are different devices available which are useful. But again, CPAP is definitely going to be your treatment. Some individuals who are severely symptomatic and are not improving despite your CPAP, you will have to go for surgery. And what is the surgical method? It is uvulo-palatopharyngoplasty. Uvulo-palatopharyngoplasty you can go for. Okay, that is the surgical method advised. But again, this is done only if there is no other way. But the most important treatment is CPAP. But never forget the importance of behavioral and lifestyle modifications. Now just summing up, remember I began this module by telling you this is a clinically relevant topic. See, many of the patients who come to you with disturbed sleep or excessive fatigue, you might be seeing a patient who comes to you who tells you the symptom that, doctor, I am feeling excessively sleepy. You see the patient is very obese. You work up for any other condition, you find that there is no other obvious cause, you check the blood for any anemia, you work it up totally except for the obesity, you find no cause. Another patient might come, he might be an obese individual, he might be having a erectile dysfunction, okay. And another patient, he says that at workplace, his efficiency has decreased so much. So he comes with all these vague complaints. Why does the patient not say that he is having a significant sleep problem? Often it is the bed partner who notices that the patient is having excessive snoring. The patient might not know this. But he might say, when you are asking how is your sleep, he might tell you that, doctor, when I wake up from sleep, I feel I am not at all refreshed. Okay. So remember, this is one entity that you can pick up. Now, why is picking up such an entity important? One is that it can improve the sleep quality of the individual. And from the discussion we have seen how important is sleep for an individual. It affects so much of daily activities. Okay, he might be having a sleeping episode while he is driving. It can lead on to accidents. He might be having sleeping episodes at its workplace. He might lose his job. So it is very important that you pick up this condition and you treat this condition accordingly. Find out if there is some secondary cause, because if it is not treated, not only does it interfere with the sleep, you already saw it can lead on to diabetes, hypertension, coronary artery disease, stroke, okay, metabolic syndrome. So all morbidities and mortalities can result. So this is a very, very important topic clinically. For your exam, they may give a clinical scenario and ask regarding management. CPAP is often a favorite question. As a factual question, they may ask something regarding the severity grading, mild, moderate and severe obstructive sleep apnea based on AHI. That is also important, and that is what you have got to learn in this topic. Okay, simple, straightforward topic, but do learn this very well. Okay, thank you.